All right, good evening. Welcome to today's webinar. I'm Danae Aber. I'm the Healthcare Innovation Supervisor with Well Ahead Louisiana. Thank you so much for joining us today. Please note that your lines are muted to prevent background noise. However, please feel free to enter any questions into the Q&A box at any time during the presentation. Today's webinar is the fourth in our Telehealth and Practice webinar series presented by Dr. Hudspeth. And today we're going to talk about the visit workflow and documentation for a telemedicine visit. If you weren't able to join us for the previous sessions, the recordings are available on our website for you to view at your convenience. All of the sessions in the series, which are listed here, will be recorded and available on our website at walpen.org/telehealth. We will also have some on-demand sessions posted on the website within a couple of months, so stay tuned for those. And then as a reminder, this series is funded in part by the TexLa Telehealth Resource Center. TexLa is a HRSA-funded program at Texas Tech University designed to provide technical assistance and resources to new and existing telehealth programs in both Louisiana and Texas. And TexLa is partnered with us at Well Ahead Louisiana to serve as the support representative for Louisiana providers. And TexLa is also part of the National Consortium of Telehealth Resource Centers. So you can access the websites and resources from all the TRCs across the country through this consortium website at telehealthresourcecenters.org. And with that, I will hand off to Dr. Hudspeth.
Well, hello, and thank you so much for that introduction, Danae. And I want to thank everyone for being on with us today. This is the fourth in our series. And just to give a little bit of background about myself, I am from a rural town. Amite, Louisiana is where I grew up. And I've kind of been all over the state, mostly at LSU, all of my life doing my training between Baton Rouge and New Orleans, then for medical school, and LSU Shreveport for my residency. And since 1993, I've been back in Hammond, Louisiana, which is my home parish. And I've been working with Ochsner for 27 years now. And I feel very honored to be in this position right now as the new medical director for informatics for the Baton Rouge region for Ochsner. And that's kind of what led me here to these nice ladies who have asked me to participate in trying to teach folks the way that we've implemented telemedicine in our practice. I was blessed to have been asked by some of our leadership to participate in our initial trials and pilot to be able to form a telemedicine program. And that started for me in 2018. And 2019, we were still trying to get our feet wet, trying to figure this thing out. And I had actually gotten all of our clinic physicians and nurse practitioners in Hammond to be doing this by December 31st, 2019. So when 2020 hit and the pandemic occurred, our work that we had done became so important for not only our personal clinic, but for our entire institution across the state. Being able to all of a sudden plug into a telemedicine practice, we went from 200 visits a month in the entire system in February of last year to over 50,000 in April in our system. So when you realize the value of that type of thing, and I know you do because that's probably why you're here today listening to this, it's just do for you. And for me personally, it has been a godsend for me to be able to find new ways to reach out to my patients, doing some of the things I've always done, but also doing some really neat things that I've never done, to be able to track them and add to the value that I can give to my patients. So in our last meeting that we had, or presentation that we had, I went through a patient's workflow, or how the patient went through their journey. Right now, I'm going to go through a provider's part in that journey. So if you were with us on the last presentation, it was a big old grid and spreadsheet with everything all over the board. There was one little square down there at the bottom about the provider's part. Well, that's what I'm going to really hone in on today, because this is where, for you and me, this is where the rubber meets the road. How do we do what we do and still be effective? You know, many folks that I have spoken to about doing telemedicine, they really first fear that they're not going to be able to competently care for a patient. And that is not the truth. For me, what it's done for me, it has allowed me to open my doors, be able to see a patient when and wherever they are and where they need me. It is, I never really thought in the past about what a huge time factor it is for patients to come to see me. Their schedule's got to match mine, et cetera. And, 30 years ago when I started practice, life was a lot slower than it is now. So now life is very fast. Everyone's busy, and telemedicine allows me to reach them and get them the things that they need to be able to care for them in a meaningful way. And those are some of the pearls that I'm going to expand on in not only this, but the next presentation also. So I saw this quote: the first responsibility of a leader is to define reality. The last is to say thank you. In between, the leader is a servant. This quote meant a lot to me at many levels. The first, the responsibility of defining reality. So when we do virtual visits, it's pretty real, okay? It may be virtual, but it is real. You are talking with people, getting into their lives, and dealing with major issues that they need help with. And if you really start thinking about what you do in your visits in your office, the majority of what you do is you listen to patients, you hear their history. And most of you who have skills, a good skill set, you already know what a patient has when you listen to them and learn their story, okay? And so defining reality, in my mind, I really have to reset people's thoughts on how we can work together and solve problems. And so even though we're virtual, I'm defining that as my new reality with them. And it's one more additional reality, okay? And saying thank you, I mean, that's just part of the empathetic thing that we do, the empathic thing that we do in caring for patients. When you say thank you, that obviously is a big deal. It means that you really cared that they came to you. And in between there, you're their servant. Servant leadership is a really neat way to run a practice. And to me, the virtual opportunity for us is to serve them in other ways that we never could before. And that means a lot to people, that you cared enough to try to reach them in other ways. So I'm trying to frame this in your mind as the way to think about it. It's not a secondary way to care for people. It's an additional way, so it's not substandard in my mind at all. So before we move on into the meat, I would like to see if we have any questions from our previous sessions that we could go through right now. So you can put some of those into the Q&A. And actually, Danae, did you have some already?
I don't see any yet, but I am looking. So if you had an opportunity to attend a previous session or even watch it in your spare time after the session, and you have any questions, please pop them into the chat, and we'll try to take care of any of those before we move on to some new content. So we'll just give that a minute to see if anybody's typing some questions.
Yeah, and we are going to try something new. In between each of these segments that I'm going to do today, I would like to stop and answer some questions, because some of what I'm going to present is a little bit detailed, and I don't want to get too far along and not be able to answer some pressing questions. So we're going to try and see if we can maybe turn the audio on at some point. Danae is going to work on that. So why don't we go ahead and move on right now, and we can pull up some of those Q&As if anyone has some, since we're going to try to stop before the end. Okay. Is that all right with you?
Sounds good.
All right. First of all, I'm going to give you an overview of what we're going to cover now. The first thing I'm going to talk about is your posture, and I've already alluded to that a little bit. We're going to go through visit preparation, conducting the visit itself, visit documentation, and then also closing. So those are our big topics, and we'll try to stop at each one of those juncture points. So posture, what is posture? That's how you hold yourself, and that's really your expectations of what you're trying to show to people. In my mind, I really had to change my posture and my entire staff's posture to really let people know this is one of the ways that we are going to do business. This is not a sideline or a side gig or something I just do in my spare time. This is a major thing that I'm going to be able to do for you. And you first of all have to establish that with your staff, because your staff are the people who are going to make or break you. They are your mouths, to be able to tell people, oh, you can do this through this. Doc cares for this kind of problem all the time through telemedicine. So let me schedule you for that instead. So that posture piece is very important, and it starts with you. Okay. So in doing that, you really have to rethink your value. I often thought about my value as, doing all the stuff physically with people. We have to start opening our minds to the way that we really get paid is evaluating issues and managing them. And when you start thinking about so many things that you probably do now for free, like, for instance, blood pressure control, management, over time. How many times have you gotten a spreadsheet of someone's pressures? You've made an evaluation of that, you manage that, and then your nurse calls, okay? Those types of things are increasing more and more. As people's lives are busy, they cannot take time out a half day to come and see you to manage their blood pressure, okay? But through telemedicine, they're happy to see you. They're happy to talk with you about their issues, answer some questions. So, I've shared this story about a diabetic of mine that, we've worked on her glucoses through a spreadsheet before in the past. And for this particular time, I had my nurse set up a telemedicine visit. The patient commented to my nurse that she felt so good about the fact that I cared enough to want to talk with her about her diabetes, okay? Instead of having my nurse just call and say, change your insulin to this and that and the other. So what I've also been able to see is that in those visits, I have great opportunities to be able to discuss really important things like their diet and their exercise, and not just bumping up a pill. Okay. So I really am able to do some of the things that are near and dear to my heart, to talk about some of those holistic things that work if we at least can get patients to do them. Okay. So this gives you one more way to do that. So we have to think about our value as a little bit different. I want to include in that, how many times do you treat common problems through a phone note? I know each and every one of you do that, because again, it doesn't rise to the level for someone to have to come from work and do all those kinds of things. But it is so refreshing to be able to care for those problems now through telemedicine. And now that I'm doing it through that method much more, I'm finding lots of times when I thought just from the message I got that I would have treated it this way, but when I actually talked and listened to them, could do some of the exam parts that I can do through a telemedicine visit, it did change what I would have done from a simple phone note. So I know my quality of care is way above what I would have done through traditional, phone note medicine, if you want to call it that. Okay. So rethink your value and start thinking about the many things that you do in your day right now that is, not productive for your practice. Okay. One of the things that I truly feel is my biggest value to people is really my relationship. When I have my relationship with my patient from my office in our, 27 years now of in-person visits, that is so monumental to a patient. They know and they trust you. They don't want to go to an urgent care to see somebody they never saw before. They would love to have the opportunity to see you through that method. And that relationship often is the piece to where when we get patient reviews, when they do after visit compliments or dinging me or whatever after, most of the time they say, it was just like I was there with Dr. Hudspeth. Well, why? It's because I look at them and I listen. Patients just want to be heard and they want to feel you cared. And that is something that is very easy to do through a telemedicine visit. So that's why when we look at our scores, our patient satisfaction scores, they usually do pretty well compared to actually inpatient visits because patients felt convenienced and it's just us looking at each other, directly at each other. And so that's what's really neat about it. So they feel great about it. And then, the point I made was evaluation and management should be remunerated. And this gives us an opportunity to do that. So I will go through some of these virtual visit types that I do in my practice, and you need to think about which one of these that you want to do. There are urgent care issues, there are chronic medical problem issues, medication refills for certain things that is appropriate. I do annual health reviews. So, the annual health physical back especially during COVID, where nobody wanted to go into the doctor's office at all. I went through everything in their history. I was able to order their labs, refill their medications, update all of my, health maintenance things that needed to be done. No, I didn't listen to their heart or their lungs virtually, but that is not the most important thing. When you're dealing with an annual health review, it is the other. So I've done that. I do a lot of mood disorder issues. Actually, within our institution, probably the largest utilizer of telemedicine type visits is the psychiatry department. It's perfect for that because you can sit and talk with people, which, is great. When I have abnormal lab reviews, like if I have a surprise lab that I didn't expect and I really need to have a conversation, but I did just examine them because, for their physical at my office, that's a perfect venue to be able to discuss something with someone very easily, to make a treatment plan and make a cooperative engagement and decision-making process of which way do we want to go with this, okay? And then I have some folks who just do healthy lifestyle planning, working on their weight or things like that. So we've done those. And our team communication, I'm going to delve into a little bit about the visit itself. Like during the time when I am in my office and I have a nursing team elsewhere, we need to be in communication. So this is about the nuts and bolts of doing the visit. When I first started this pilot, I was seeing maybe 2 or 3 patients a day in this, but all of a sudden when COVID hit, my entire schedule was nothing but telemedicine. And so I was in my office and I had to be able to communicate with a nurse. So you have to think about that if you're building a bigger practice. How are you going to communicate with checking a patient in or checking them out? Sometimes I'll see it's 9 o'clock on my schedule and the 9 o'clock patient hasn't checked in telemedicine wise. Well, they may be having some kind of an issue with logging in, understanding it, et cetera. So my nursing team, if I basically have a secure chat that I'm able to do with them, and I ding them, to let them know the 9 o'clock patient's not in. So they really go into tech mode. It's almost like a California startup tech company, out in my nurses station sometimes, making sure they log on appropriately. Well, for us to do all of that, you have to think about your communication piece with your nurse. We do have something called Secure Chat that is actually inside of our particular EMR that we use. So your EMR may or may not have that type of capability. We use Epic, and you need to think about that. If you're still looking for a platform, having something to interface with a nursing team or anyone on your team through that method is great. I can attach a patient's chart to that message. So again, it speeds my nurse's response time to be able to pull that chart easily and to make sure we're talking about the right person. Some people actually in my own office use the Microsoft program Teams, and it's a very useful tool. And it's basically an instant messaging service. So you might want to think about that one if you have Microsoft in your office. It's a very good tool. And then there are some third-party tools that can be used also that are HIPAA compliant if you want to do some secure messaging with folks in your office. So I'll stop right there and see if any questions came up during that particular time frame. Anybody want to speak, or just type in the Q&A?
I don't see any questions in the Q&A. If anyone would like me to unmute them, I think I have the ability. I see a button to allow people to speak. So if you want to just pop into the Q&A that you have a question or a comment, then I can check the button to allow you to speak. And then Dr. Husbeth, just let me know when you're ready for our poll question.
All right, I will. I have that. I actually made a slide for that, so I'll bring it up in a minute. All right, so to start off with, you have to think about your environment. And you sometimes have to think about your patient's environment. I'll tell you a little story about that in a minute. But think about what's behind you. It's best not to have doors or windows because someone may be coming in the door, or with the window itself, it makes a bright light. So when the light is behind you, then it makes your face dark, and you really want to be lit up. You want to make sure that your wall is if you don't have like something nice like a bookshelf that's well kept and that kind of stuff to look stately or whatever, a matte finish wall is perfect for that. For some programs, people can put up wallpaper behind, like I have a wallpaper behind me right now. But if not, just a plain old wall is fine. Your lighting, as we talked about, you need to have some light coming at you from the front. Many folks use a little, stand-up light a ring light. They sell ring lights for about $25 that you can get. For this particular presentation right now, I actually have 2 ring lights because I am very worried about reflections in my glasses, okay? Or for me, reflections off my forehead, okay? So, you have to kind of think about those things. How are people seeing you? I try to use earphones. That way I feel like I don't have to talk too loud to my iPad, because I do all of mine off of either an iPad or not my iPhone, actually, through an app. So I try to use those earbuds because I can hear people very well, and mine are noise canceling. So I don't hear a bunch of outside noise. Besides working this at my office, I work 2 days in Baton Rouge doing endoscopy, EGDs and colonoscopy. So 2 full days of my week, sometimes I'm doing patient care over there. I do it sometimes in my home. If I have a day with a lot of meetings because of my leadership role, then I may be home, but I may be interspersing that. So I want to be prepared wherever I am to be able to care for my patient, okay, and in a nice way that they think I'm, normally where they expect me. Let's see. You want to turn off applications in your on your computer. You don't want pop-ups to be coming up during the time that you're seeing a patient. And you want to position that camera at eye level, just like you're speaking with them at your office. You want to try to center your face in the field. And I talked about my noise canceling headset, which I love. And those are just in-ear buds is what I use. I don't use, the big ones on my ears or anything like that. I do put a sign outside of my door when I'm at my office so that people aren't barging in, interrupting me during that time. And I try to, wear clothes that aren't too flashy or with weird designs or anything like that on it, because sometimes that will blend in with a background or really be a little bit, I guess, distracting to a patient if you have that. We try to get people to not wear big flashy jewelry. Again, you're trying to avoid distractions and that kind of stuff. I talked about the glare on my forehead and my glasses that I try to avoid. And of course, don't do things that you wouldn't do in a normal visit. Don't eat or drink during the time that you're there with them. You want to be focused on them, okay? And then you want to make sure that you have your camera stable. If it's for my iPhone, when I'm using it, I have a holder, a little short desktop holder that I use, and so I'm able to position it. It'll keep it steady, and you don't want to be walking around when you're doing this either. Okay, so any questions on any of that at all?
Nothing on this end.
All right, good deal. Must be explaining it good then. So we're going to talk about conducting the visit itself. Okay. So when you enter into the visit beforehand, you really want to know that patient. Okay. One of the things that we track in our clinic, just when we're seeing in clinic patients, one of the questions that patients are asked is, did the physician know you? Okay. Well, that often is enhanced if you just look at the chart before. And I'm sure most of you do that. In our world now where we have an electronic medical record, the computer's in the room. So it's a little strange. We used to flip through the paper chart before, right outside the room before we go in. So that step has been taken away from us. We have to do something extra now to be able to do that part. So you have to either be at your desk, et cetera, in a regular world, seeing patients in the clinic. Here, you've got your computer in front of you. So before you click on the video, at least look at what the patient's there for and try and refresh your memory. Those are just good practice things, whether you're seeing a patient in the clinic or virtually, okay? Identify yourself to new patients, obviously. Now, it's maybe surprising to even have this on here, but back in 2016 or so, I was asked by my institution to start working with physicians who didn't have very good patient care encounter scores. And in learning how to help physicians do better with that, we actually would video physicians in 3 visits. Those would be sent to me and I would review them and then go and sit with the physician. You can't imagine how many times that, and these physicians knew that they were being videoed, how many times they just walked in and didn't even introduce themselves to patients. It really amazed me. So I feel like in my virtual visits, I'm trying to implement some of those skills that I learned by teaching others on how to do better with their scores. I'm trying to implement those skills of just the right thing to do to have a patient feel like they're being cared for appropriately. Okay. So identifying yourself to patients is a very big deal. And some of these things are new. Patients are new to your practice. You want to confirm the patient's identity and location. Legally, if a patient is on vacation in Florida and you don't have a Florida license, you should not care for that patient. You are technically, practicing without a license in Florida. The onus is on, where the patient is located. So make sure where they are so you're not doing something wrong there. You want to make sure that they can hear you, make sure that and see you. So you want to verify that their um, um, video is working and that they can understand you well. And I always try to discuss, if we get disconnected, I'll call you if we've already done our physical part, so I'll talk with them about that. And that occasionally happens in different scenarios. I do ask about privacy. It is amazing to me when I will get into a discussion with someone and they'll start sharing some pretty sensitive things. And later I find out there were other people in the room and maybe I shouldn't have asked a question that I wouldn't have asked if I knew someone was there. So I didn't used to do this, but I'm really trying hard to make sure, is anyone else there with you helping you with the visit today? And man, I'm seeing that a lot of times there are other people in the room. And so I do try to ask them if they're helping them with that visit, and that actually allows me to start exploring, who else is helping in that patient's care, especially if it's an elderly patient. It allows us to open the door to talk about, some of the issues like, are they helping you with your medicines? Did they help you in the visit? Can you conduct a telemedicine visit by yourself, et cetera? And it also opens the door, since we have an online messaging app. It's called MyChart. A patient has a portal. They can look at their labs, see their visits, send messages to me. What I love doing is opening the door to ask if that other person in the room is their proxy in their MyChart or helping them out with their care. And a lot of times, if it's an elderly person, it does allow us to kind of solidify that relationship, that it's okay to talk to that family member. And so that's really a nice thing to do. And it a lot of times emanates from these visits where the proxy person is now helping them out, getting them into a visit. also creating a patient safety plan in case of a crisis. So if someone's has a pretty urgent issue, this is something that I do. Obviously, I don't do this on every patient, but if it's a pretty serious problem they're having with me, I want to make sure that we know where we're going in case we get disconnected, et cetera. And then I really try to keep the visit as much of just like an in-office visit with me. I want to use friendly body language. I want to, I really focus on, my facial expressions. When people are talking, I have taught myself how to look and make sure that I'm raising my eyebrows. I don't have all of my body language that I can use like when I'm in a room. I can't use that touch that we often use when we're trying to, really communicate and get to know a patient or have them feel cared for. I can't do that. I can't touch, but I can use my facial expressions, be focused on the camera and that lens to make sure that they understand that I'm hearing them, I'm listening to them, and that has helped me a lot. So we talked about the introductions, make sure they hear us well and adjust our cameras if needed. I actually try to get them to state the purpose. I do that if I have that in my listing of why they scheduled, just so that we understand what's the purpose of today. And first of all, I want to make sure for myself that I can care for that type of problem, through telemedicine, but also to set expectations for the patient of what we're going to be doing today. I do ask, as I told you about, the other people in the room, and I question their participation. And I also narrate what I'm doing. So I try to, when we first start talking, I'm a big stickler about that old 18-second rule that we probably all learned in medical school or residency. There was a study that was done that said within the first 18 seconds of an average patient visit, the doctor interrupts them. Well, I've been a big stickler about that since I started in practice. Conversation is a two-way thing. If you just let someone talk and never say a word, it's not a banter. They're going to kind of say their piece. And so if you just be quiet for a little while, let them say their piece. They know most of probably what you need to make a decision about what their problem is. Once they finish, then you can start chiming in and you can take hold of the visit. But you have, once you've done that piece and stopped the listening part, that's where you start needing to do some other things. You need to probably go into their chart, look at their medications, and click on previous labs that they've had, et cetera. Well, while you're doing that, you're not looking in the camera. And again, I want a patient to feel like you're interested in them and dealing with them face to face, eye to eye. But there's a point at which you need to do other things. Well, they can't see you doing that. They don't know what you're looking at unless if you narrate that. So I try to narrate, oh, let me look in your medicine list right now and let's go through that. So, I actually reconcile their medication list if my nurse has not done that for me before, or if I'm needing to ask some pertinent things about their particular medications, then, we'll start talking about that. Oh, I need to look at your labs now. I need to see what your last A1C. Let me go to that area in the chart. So I'm not looking at them, but I'm telling them everything that I'm doing so that they can understand, what I have in front of them. So again, that's another thing that lets them feel like you knew them. You were able to have every piece of thing that piece of information on them that you would have had in a visit at the office. Okay. So again, that helps. Sometimes our bandwidths are not the best with patients if they're especially in a rural area. So I do try to stop at a certain point and let the transmission go through, because sometimes there is a little bit of a delay. And it can be a little bit awkward if, they're trying to talk and then I'm trying to talk, and most programs don't allow everything to kind of go through all at the same time. It's either one way or the other. So I try to think about that delay after I speak. Okay. I do have to speak a little bit more deliberately and, say my words a little clearer because we're not in the same room. And I also after I'm done with everything, I really am a stickler about trying to go through the plan. It might be, it seems like it's a little easier when you're in an office to be able to go through the plan, but with this, you really have to do it because you often don't have, many programs don't have a capability of giving an after visit summary like you do in your office. That is a huge feature to me. If you're looking for a platform, really try to think about having a platform that can convey that after visit summary to them, because it really tells them what their next step is. And unless you think about that, then it's all dependent upon what you are going to be telling them. Okay. Going back to those days when I was telling you that I worked with the physicians on their patient satisfaction scores, that empathic language is really critical, and it can make or break you. So after you've listened to someone and you tell them, it must be difficult for you in this situation. It sounds like you've had a really hard time with that. Being able to choose those phrases really resonate well, whether you're in a clinic or through a video conference with someone. So those are some really good things. And I already talked about the nonverbal language that you use, like raising your eyebrows and things like that. Your smile, all of that stuff is very important and makes a patient feel heard, which is what they want. As I tell you, I summarize everything at the end and try to reflect on statements that they have told me. So that's the active listening thing. They'll say something and I'll say, oh, sounds like you've had blah, 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 and I kind of go through those things. I do ask questions if I need something to clarify something. And I try to use a lot of open-ended questions. I mean, these are all things that we do in our office. So none of this is different. I try to make sure that their priorities guide this. In telemedicine, I really feel like people book or schedule for a problem, which is very unique because many times in my practice in the office, I get the list. And I guess it's the mindset of people that are scheduling with this. They are very focused on their one problem usually when they are booking with you. So if there's something a little bit different from what was scheduled, I certainly let them guide that. It may be a little different than what's on the paper. And then, of course, that shared decision-making process that we should be doing in our office too, and patients really value that a lot. That actually is one of the big three key drivers in our institution's patient satisfaction study that was recently done. One of the key drivers was sharing decision-making processes. And that is something that you can very easily do in a telemedicine program if you choose to, okay? And then at the end of the visit, I always ask them, what else can I do for them? Most of the time, just asking that puts them at ease to make them feel like you weren't rushing them through the visit. Vast majority of times people do not have extra things to ask me. They've already asked their piece and had it satisfied. But it's one more little tool that you can use to make people feel like you weren't trying to just rush them off of the platform. Okay. So I love this saying, 90% of your diagnosis should come from your history and 10% should come from your exam and testing to prove what you already believe. I think most of you, if you really think about your practice, this is probably true, especially for the seasoned physicians out there. You already know what people have if you just listen to them. And through telemedicine, you can do that all day long. And 90% of the time, that's all you need is the story, an appropriate story. So when you wrap all the other things that you can do in a telemedicine visit, like make the patient feel cared for, like you knew them, et cetera, and then you actually provide the care that was needed, and you may need to do some additional lab testing or follow up on some certain things, okay? But a whole lot of things you'll be able to care for straight through this. Okay, Danae, can you put up that poll for me?
All right, you should see the poll on your screen now, and you can actually select multiple on this one.
Yeah, if you currently provide telemedicine visits, select all of the problem types that you care for. I'm interested to know this, and we'll pull this up at the end to see what everyone is doing currently. Again, I do these polls mostly for myself because I want to see what you're doing.
And Dr. Hudspeth, while we're letting people respond to that poll, we actually have a question in the Q&A.
Beautiful.
Someone asked if you could describe the holder that you use for your phone when you're doing a telemedicine visit with your phone.
Yes. What I use is a little tripod, and at the top of the tripod, it actually has a holder. So I'm going to actually pull this over. I don't have the one that I use. Oops. I think I kind of messed up a little bit there. There we go. I'll show you this if I can. It looks like this. If you see, can you see that? It has a little holder where the phone will fit in there. And you see this right here is it's a little stand. The one that I use at my desk, it has a tripod. This one is hooked to basically like a clamp, and it'll clamp to the table. But the one that I use in my office is actually a tripod. Okay. They make some that the tripod will actually extend up or down. So then depending on which table you're on, you can make it fit just at the right height. Okay. All right. So what I'm going to do now, I'm going to run through some visit documentation. I'm not going to be in great detail on that because the system I use is Epic. I have actually provided some templates here that I've taken out of Epic. I'm going to breeze through this kind of quickly, providing you with some pearls about just the visits and how to entice people to do certain types of visits, and then how I'm able to manage that. Okay. But in another presentation, we're actually going to do chronic illnesses and urgent care illnesses, and really flesh those out a little bit tighter than what I'm going to do today. Okay. This is strictly as a reference to you, that you can go back into the presentation and see how we divided some of these visits, ideal patients to use them on, conditions and treatments that we can provide, et cetera, and some of the billing codes for that. So that's just a reference for you to look at later. In going through urgent care, there's a whole lot of things you can do with urgent care. But in urgent care, we actually have to have a certain introduction. And I said urgent care. This is any care through telemedicine. You have to have certain components to be legal with the state board. And basically, you have to document the location, your chief complaint, the time spent with the patient. That's how you do your billing. And you have to type in there the virtual visit with synchronous audio only and video. Okay, that needs to be part of it. So, and then talking down below, it's more a little blurb about the consent that is required to be able to do a telemedicine type visit. Okay, that's why when you choose a platform, you need to choose a platform that you can easily obtain a consent from the patient. Okay. So you could basically lift this out and put it on every single telemedicine note you ever have. Okay. And it will satisfy the needs. The three asterisks here are in Epic, the program that I use for documentation. When I type F2 on my computer, it actually pops to the next asterisk. So that's a wild card. Okay. You can utilize that wild card for anything you want. All right. And that's why it's different for different patients. I can just toggle through those very easily. Okay. So I have one template for a generic telemedicine note. Okay. And this is again, a lot of Epic speak, all of these @ signs and all that kind of stuff. But if you kind of look at it, it's the subjective and the HPI, which in that HPI, you see, I have a wild card because this is a generic note. I could just type in or dictate later what the patient told me. But all of these other @ things like that will pull up their health maintenance that is due out of our system. It tells me if their mammogram is due, their everything, A1C, anything that we track is going to pull into that note automatically. All their social history pulls in. And actually, in our system, the patient clicks on a series of review of system items before they even get into the visit. That's all pulled into my note automatically by these call functions, which is so nice. Okay. I do have specific physical exams that templates that pull up for various things, and I can just click back and forth on that. So that presents an option for me as I'm seeing the patient. And then whatever assessment or impression and plan I have had, this note pulls all of that data directly into it. So a whole lot of my note is actually done through that method. So when in looking for a platform, you may already have some of these features in your own EMR, and you may be looking for a platform to do telemedicine that interfaces with that or not. You know, some people are just using on the telemedicine piece, it's just the video component and audio component. They're still using their same old EMR, okay? But I'm presenting these to you to sort of give you a backbone of how you may want to use some of your own templates in your own EMR, since you're going to be doing this all of the time, okay? I did want to kind of focus on this and provide this as a resource for you too. These are common physical things that you should be able to see and do and document in a visit over telemedicine. So look at this, use it as a reference for yourself, but this is pretty extensive on things that you can actually document. All of these, I just typed in kind of the normals. Well, obviously you can add in the abnormal things as they arise for a patient, okay? Next, what I'm going to go through is hypertension and diabetes. Now, this is the bread and butter of most of our practices in primary care. And I alluded earlier to a patient, you know, bringing in the spreadsheet, so to speak. Well, the majority of how I use this now is when I see a patient with a scenario, their blood pressure or their glucose is unmanageable. You know, it's high. It's out of where it's supposed to be. And I make a change on their medication, I'm going to need to follow them up, right? So this is what I do. I tell a patient, and this is my script, steal it, okay? This is for your use. I usually follow up on this type of problem in 2 weeks. I offer, one way that I do this now, I now offer to do this through our telemedicine service, which is like doing a FaceTime visit through your phone. You can do this from anywhere and don't have to come to my office. If you want to do this, I can have my nurse arrange a virtual visit for you, okay? It's an easy script and it offers the patient an option. You're not telling them you know that this is how you're going to do it, but give them the option. Well, how many people do you think when offered, you know, do this simple thing, you log in, or you got to come to my office, it's probably going to take you a half day off of work. You're going to wait around other people who may or may not have COVID. You know, you're going to wait for me 30 minutes because I always run late. You know, so what choice do you think they're going to make? Again, you are defining reality right here. You are defining your reality, and it's your posture of how you're going to do business and how you can do business, okay? You're leading them. It's like that quote that I gave you about leading people, okay? You're leading them to the place where you want them to go. And most of the time, they're going to follow you, okay? And I use that script intermittently on lots of problems, okay? So let's see, I need to, the action that we take is my nurse goes in and she schedules for a telemedicine visit in 2 weeks. And in our program, I'm actually able to have the patient enter their data directly into their portal or their app. When it does that, it actually comes to our system. So I'm able to look at 2 weeks of data. And in 2 weeks, when I see them virtually, I can pull all of this data into my note. Believe it or not, I have a template for that. It pulls that data automatically. So when I pop up my telehealth hypertension or my telehealth diabetes note, bam, there it all is. It is so neat. Okay. Again, that's a Cadillac way of looking at it. But there are other programs that you can at least reference the data that maybe they've provided for you. The key here for you is you are evaluating someone and you're managing them. That's an E&M, okay? And that's how you need to have your posture and to rethink yourself and how you provide care, all right? And it also, again, gives you that opportunity to talk about, did you get on the diet we talked about? Did you start walking? You know, those kinds of things. So we set them up for that 2-week telemedicine visit, and we reschedule them as needed. If I make an additional change, then we'll do it again, okay? It's a very easy process. This next little thing here is just, that's my template that I use, and it's split into parts here. I wanted to go to, actually, if you look here on the at REVFS and all that verbiage, that is actually the call function for all of the patient's values that they've put in the last 2 weeks to be pulled into my note. Okay. And if you see here, I have a very cursory physical, so to speak, over things that I can see or hear over the telemedicine. And I have those all plugged in as normals. I'll change those on the fly as I need in my notes. Okay. And then again, just like my regular visits, it pulls in the impression and any medication changes that I made. It pulls all that data in automatically. This is the same thing with diabetes. And if you see down on, let's see, I'm going to the next page, that REVFS 415 and all that, that again is going to pull all the sugar numbers in for me. Okay. So I provide these just as templates for you to see what I do, and then you can make it accordingly to how your EMR works or how you go through things yourself in your history and your exam when you see them. Are there any questions on that particular problem, hypertension and diabetes?
I don't see anything in the Q&A box at this time.
All right, we'll run through anxiety and depression. I mentioned to you our psychiatric department uses this program heavily, okay? So the scenario for me in my practice is I've changed their medication or started something new for either anxiety or depression, and we need a follow-up. So what do? I usually follow up this type of problem in 2 weeks. I now offer this to be done through our telemedicine service, which is like doing a FaceTime visit through your phone. You can do this from anywhere and don't have to come to my office. If you want to do this, I can have my nurse arrange a virtual visit for you. It's the same script, okay? I just plug in a different problem. Our action is really a little simpler because in this, scenario, I don't have to have the patient taught about entering blood pressures or sugars and things like that. It's just make the visit and make sure that they understand how they're going to click on their app and get into the visit when it's time in 2 weeks. Okay. This is the template I use. You can use it or lose it, yourself to, as to how you want to document things. I'll go through attention deficit disorder. This is something that we can do via telemedicine. Prior to COVID, the standard of care was that number one, you had to see a patient once a year in your office. So if you're doing these follow-ups, every 3 months, that means visit 2, 3, and 4 can be through telemedicine. But the main physical component that the board tracks you on this and wants to see you document, which is, for appropriately treating a patient, is what's the blood pressure, pulse, and weight, if it's a child. So you have to be able to, in my opinion, document their blood pressure and their pulse. So what we actually do when we enter someone into doing this program, we have them bring a blood pressure cuff to our office. We make sure that it's calibrated by my nurse, make sure that, it's approximately accurate. And then we put that into the chart. So we have something to go back on to show that, that we went through that. And then prior to the visit, the patient is taught that they enter their blood pressure and pulse in the app. And then when I open my notes, bam, there's my blood pressure and pulse. Okay. Sometimes people are not quite as savvy as I'd like them to, and they will actually do it with me watching them. Our system actually allows me to be able to snap a photo. So sometimes I'll have them hold up their blood pressure cup to the screen and I'll snap the photo of it. Okay. And I'll put that into the chart because I can pull that into my notes. Again, the scenario is just like what we did on the other. we need a follow-up. And I use the same script, so you can just insert a different problem. We talk about that action. I just kind of went through all of that about how we need the patient to be taught how to use their apps to input the data. And, through here, I also definitely document about our PMP observance, that we look at the PMP, and we can do that directly out of our system too. So it makes it very nice. This is a template that you can use, that I use. It is what I document in my ADD notes. Specifically, I do talk about the PMP in this and make sure that I do that. I talk about, what visit they are on. If you see this, the wild card /4, I want to make sure that I'm keeping up with what visit this in that series of, 1 out of 4 in my office versus through telemedicine. Now, with COVID, we have a lot of things that we can do through telemedicine now that we didn't used to be able to do. So especially with some of the controlled substances like this. For anxiety and depression itself, this is, again, a template that I use for my anxiety and depression documentation when I'm doing those kinds of visits. And so I'm going to go quickly through just closing out the visit. In closing any visit, I want to review that diagnosis and plan so they understand. I provide a after visit summary. You need to try to do that if you can. Our program does that automatically. I give them the next steps of what to expect, so that if it's going to be, lab work or something like that that needs to be done, then I'm going to be having my nurse reach out to them to complete all of those tasks. So I make sure they understand what the next step is when they leave you. I then personally have to route all of that directly to my team for them to start taking action on. And we do that through our EMR. I'm able to route it to who I want it to go to. As I said in the end of that quote that I gave earlier, thank the patient for joining you in this new thing called telemedicine. And I often ask them, how was it for you? What did you like about it? We're still building it. What would you like us to do better? So I do actually ask that, because I'm in a position to make some changes within our institution since I was part of the pilot, which has been nice. And then, of course, I complete my notes and I do my billing. So for you guys, we have a list of resources. I'm going to keep adding to this as I find new resources that we have. These are all in the PowerPoint, and you can go and click on some of these if you're looking for a telemedicine program. I'm just clicking through these so you can see some of the things that we have. Then the main resource is, Danae. I can't say enough good about Danae and Tracy over there. They are leading this charge with rural health. They are ready and willing to help you if you have questions and to direct you where you need to go to try and implement your own programs. So all of these will also be posted online. So these are the links to that. And we'll throw it open for questions now. Any final questions?
I'm not seeing anything in the chat. I am going to share the results of our poll for you.
Okay, urgent care, 50%. All right, hypertension, diabetes, lab reviews, healthy planning. Excellent. Okay, good deal. Yeah, I didn't go through the hypogonadism. That's getting a little more and more in my practice. And I included ED in here. There's a lot of companies around the country that are doing this now. They basically are doing hair loss and ED and all that kind of stuff. So this is getting bigger and bigger around the country. And a lot of companies are starting on these very niche problems, but they will expand, I can promise you, over time. So I feel that's a segue to say it's important for you to start your telemedicine program now. Other folks are going to be doing this, and it is so easy for a patient to log in and establish a relationship with someone who may not be in their community or know them, but ease of use is going to trump a lot of other things in the future. One study that I saw, patients ranked things that they valued as most important for them seeing a provider. Number one was the timing of when they could get an appointment. Number 6 was the quality of care they received. That's pretty big, in my opinion. That's what's important to people right now. It's a consumerism market, and this is a perfect way for you to be consumer driven and giving patients what they are wanting today. So, if there aren't any final questions, then we'll close it out for today and wait for a couple of weeks. Y'all join us again.
Yeah, thanks, Dr. Hudspeth. So as a reminder, the slides and the recording will be on our website at walpen.org/telehealth, and you can also submit questions on that page. Our next webinar is going to be at the same time in 2 weeks, March 11th, and it's going to get into more detail about urgent care and telemedicine. And actually, after you exit this session, you should get a survey question that'll pop up in your internet browser. And it's just one question that's asking about topics to cover in future sessions. So we still have a couple of sessions in May and a couple in June that we haven't finalized which topics will be covered. So please go ahead and answer that survey and let us know what telehealth related topic you'd like Dr. Hudspeth to cover. And we'll consider those as we're deciding which topics to do. So as always, please feel free to reach out to us with any questions at any time. And if there's no more questions, thanks and have a good night.
Take care.